With your permission, may we now move on to item 7 on the agenda, which is board committee feedback. I'd like, with your permission, to add a report of a decision that's been taken out of cycle by the Directly Commissioned Services Committee. And this is to do with liaison and diversion services. These are services provided for people passing through the criminal justice system, particularly those with mental health, learning disabilities, substance abuse and other vulnerabilities. The current estimate is that about 1/3 of police custody suites and courts in England currently have liaison and diversion services in place. 10 of our area teams have been working closely with partners at national and local level in commissioning the services. But an outline case has now gone through Treasury and received approval for further investment. That's giving an additional investment of around 12.9 million for the next 2 years, over and above the 21 million that's already flowing through the system. And Department of Health are now preparing to hand over operational responsibility to us for the services. With the funding and in light of our engagement already in commissioning the services, the committee were persuaded that this is something that we should take on and accept, and to take on the operational oversight of liaison and diversion services, subject to a final review of the transitional actions by the programme board. So can I say, I'm not seeking approval of this board. It's a decision that's been taken by the committee as a matter of urgent business outside the normal cycle. Are we happy? Well, I'm not. I'm not asking you whether you're happy.
But we are
quite honestly. But
we think it's a good decision.
We would be if you went to that.
Yeah,
good.
we think it's a good decision.
Well, while you're in that positive mood, may we have a quick report on the Efficiency and Controls Committee?
Well, I think I can make this efficient by not commenting on it. Everything you need to know is in the report. You'll be pleased to know the committee has been very busy since we last met, including, as you can see, on Christmas Eve, which just shows our dedication to the duties. But there's nothing much beyond that I need to say.
Thank you very much. Done. Finance and investment, Moira.
Likewise, I don't really think there's anything I want to draw the board's attention to at this point.
Well, that then sets the model for me on business planning. You have the paper in front of you. I think the critical thing in the business planning is identifying the 4 key areas for prioritisation, which are in paragraph 4 of the report. I won't go through them, but just to say this is a major item of business for us, and we will be bringing back further papers to the next meeting. But this is an absolutely critical time in the preparation for the business plan for the next cycle. Okay, and then we go on to the task and finish group on the on congenital heart disease. I have to say that I did report, I think, on the October meeting to our last board meeting in December, although we didn't have the formal minutes at that stage, I believe. And I didn't chair the meeting on the 7th of January, but Ed did. I mean, before I invite him to say anything about that meeting, should he wish to, just to say how important it has been that this process has been conducted with transparency. And the novelty of John Holden's blog and the communication and the engagement with all stakeholders as we take this painstakingly, as we must, step by step by step, to the ultimate goal of having a proper national process for commissioning congenital heart disease services. Ed, is there anything you'd like to add about, in particular, the meeting in January?
We have a good meeting, the minutes will come through, but I mean, again, we supported the progress on standards, which is progressing well. We pushed quite hard on the timetable, recognising this is complex, and looked at the team to come back and say, what can you do in parallel rather than just in series. And we had Sir Michael Rawlins there, who talked about the great work that's being done in the clinical advisory panel, which is so important as part of this. And I think in your absence we suggested that you might like to attend one of his clinical advisory panels, just to reinforce the importance of that clinically led work, and that was certainly supported. So sorry about that.
Well, no, I mean, I agree with you. It's so important. I'm delighted that we have Mike Rawlins involved in this and helping us to guide us through on the clinical aspects. Okay, well, thank you very much. And I have to say thank you to everybody who participates in the committee work of the board, because this is not trivial. And although we conduct it with some dispatch here at the main board meeting, it's a very brief summary of what's been quite a high volume of quite complex work. May we then move on to item 8 on the agenda, which is the finance report. Paul, over to you.
So I know this is your favourite part of the agenda, but on this occasion I'm going to keep it very short, partly because it's only just under 4 weeks since we last discussed this at considerable depth, and partly because the meeting is slightly unfortunately timed, because I get the latest set of numbers literally later on this afternoon, which makes it a little difficult for me to comment on very up-to-date numbers. So what you've got in front of you is just the interim update on month 8, the detail of which obviously has been scrutinised by the Finance and Investment Committee at its meeting earlier in the month. I draw your attention to Appendix 2, which brings it all together, and the broad message I would give you is that there is little change to the financial numbers between month 7 and month 8. What change there is on the whole positive change, particularly in terms of CCG performance, both in aggregate and the number of organisations which are struggling. Very, very small positive corrections going through there. The other thing which has moved positively is the running costs and programme costs of NHS England, where we're continuing, I think, to underspend on those as the year goes by, though that's a declining picture, as it were, of underspend. So all in all, a steadily improving picture. As the paragraph on the risk-adjusted forecast says, if you like, a lot of the risks are beginning to work their way through the system, so the net improvement at that stage is more significant. But I think let's hold off until month 9, which will tell us in rather more depth what's going on, and then clearly the major thing is how that translates itself into the challenges for the next 2 years and 5 years and beyond that we talked about in December.
Good. Thank you very much. I don't detect anybody wishing to go further on that, so thank you very much for the report. May we then move to item 9, which is the board assurance framework, and invite Bill McCarthy to introduce it.
Thank you, Malcolm. Similarly short, given that we discussed this at our last meeting, I'll just draw out 4 points, if I may. I think the first is to say that we are and will continue to report the additional mitigating actions around these risks. So this isn't a presentation that we bring to the board periodically. It's an active part of our management process, and between times people are looking for the additional piece of work, the additional mitigations that will give the board the best assurance we can that all of these risks, which of course are risks to our delivery of better outcomes for patients, that we're managing them as best we can. Secondly, the one movement, if you like, on risk this period is around NHS 111, where we believe the actions, mitigations, as we've understood more about that business, that now is a declining risk, and that's reflected in the summary. Third point is just to highlight that actually I think there are 8 of the summary risks that we're taking on the board somewhere else in substantive discussion today. So I know Chair of Audit Ed's very keen that there is a link between our understanding of risk and then the business the board does, and I think I can give that reassurance. And finally, just to say that this is probably the last time you'll see the BAF in this format, but Barbara's been leading I think some really important work to simplify and clarify so it becomes increasingly accessible, helps us to give the assurance the board needs. With that, I just recommend we accept the report, Jim.
So we'll have it in this format for the remainder of this financial year, but launch the new format for 2014-15. Good. Any observations, Ed, intent? Okay, thank you very much, Bill, for that. May we then move, please, to item 10, which is the winter planning update. Barbara.
Thank you, Chairman. I won't go through the individual elements of the paper, which updates the board at the time of writing on all the elements going into supporting winter planning. We're now in what is traditionally one of the most difficult periods, and I think since the paper was written, we've continued to see the NHS deliver services for patients in a timely fashion, as measured by the 95 standard, and I think that we should thank all the staff involved, whether they're in hospitals and A&E units or out in the community helping patients to stay well and stay at home, because at this time of year it is challenging, and the NHS did a really great job over the Christmas and New Year period. The figures for this week are equally encouraging. So for the last several weeks we're round and about the 95%, slightly over it this week, which is encouraging but you know, there still is a significant amount of winter to come, and we need to continue to be vigilant. The paper details the money that's been distributed to the NHS to help and support them, and you know, we think that this is beginning to have an impact, because what I think the figures are showing us at the moment is that the system has the resilience to cope. One of the disappointing figures, I think, is that whilst patients are seen in a timely fashion, we see an inexorable rise, particularly in admissions and to some extent in attendances. 111 is holding up very well. We're getting good response rates from 111 and great patient satisfaction. But we do need to continue our work on what goes on out of hospitals, to try and make sure that if patients really don't need to be there, then we've got the systems in place to ensure there aren't. And I think we do want to put a strong emphasis on that work out of hospital. And part of that work has been working with the independent and voluntary sector, which has been widely reported recently. This is mainly about ensuring that when patients are fit to leave hospital, they can do, or don't need to go into hospital, because what we all know is that the pressure on the accident and emergency unit is when they haven't got beds for patients to go into within the hospital, and we all know that there are patients in hospital who would prefer to be elsewhere if the beds were appropriate for them. So we've had some very good work with the voluntary sector, who have come up with a range of initiatives that they could help us with patients at home, and the independent sector, which is dominantly, of course, about nursing and care home beds, which are predominantly provided by the independent sector. Our national negotiations have been about what can we do at national level. We don't have an oversight of contracts at local level, but what can we do at national level to help people on the ground work more closely together. And as the next few weeks go by, a range of those work streams will hopefully come to fruition and help people on the ground, and will be there for next year, even if it's a bit late for some issues this year. So the main thing, Chairman, I think is good news. NHS staff are doing a really great job. The NHS is holding up well, but we need to continue to be vigilant.
Well, thank you very much, Barbara. I think everybody on the board would endorse your commendation of NHS staff working through these really difficult conditions. I think the other thing that we would wish to consider is how we bring forward winter planning for future years, and we've touched on this before at meetings of the board, and if we can ensure that those initiatives that you've just been talking about, which are in the process of being established this year, are properly taken forward and become part of the general wiring for the preparedness of the service for winter, that would be a really quite big step. And getting away from funding decisions sparking reactions into something which is more measured through the financial year would be
We've actually already initiated the winter planning for next year, which is several months ahead of usual, and I'd be more than happy to bring a report back to the board either the next board meeting or the one after that on our plans.
Great, I think that's exactly what we would like. Thank you very much. Moira?
Explain my ignorance. Is there a seasonal impact in mental health services? A seasonal impact in mental health services, thinking about parity of esteem and running that through all our discussions. Is there are there anything like similar issues in mental health?
I would have to
check on that. My understanding is, I think from memory there is, because of the kind of depressing times that we have in winter when the weather's not so good and it's dark for more hours. I think, you know, one of the biggest issues always is that we shouldn't underestimate how much helping people with mental health issues to stay well is really important for taking the pressures off acute services, because the two are just inextricably linked. Patients with mental health issues, often their physical health deteriorates, and that's a real problem for them, and often at times when patients with mental health can't find anywhere else to go, then they end up in the A&E department, which you know, most importantly is not the right place for them, so we need to offer something different, but doesn't help the pressure on the department at the time. But I will, if I can, come back to you on seasonal variation in mental health.
I do think this early planning thing is critical, not least of all if there are resources to be allocated out to the NHS and social care systems that need to be allocated out. I mean, you would hope really quite soon rather than wait till the last minute to do that. I think the mental health thing is really important. I think one of the group that has biggest users of 111 is people with mental health problems. I think we've got a lot of data now about that we've never had before in relation to all of that. And if you look at the frequent users of A&E departments, a large proportion of people in mental health. So I think it really works quite. We've
got 7 work streams already on the go for next year as to get ahead of the game, and one of them is mental health, is how it's spot.
And I think we'll come on in a minute to talk about urgent emergency care more generally. And I mean, I visited Barnsley Hospital on Wednesday, the A&E department. They were doing fantastically well. I have to say it was very, very impressive that they do there. But increasingly they're thinking about 7-day services as doing that. I'm working with local government to see how they can create 7-day services in both social care and in healthcare. And so you can see how these things can connect together to make a real benefit for patients.
Good. Well, thank you very much, Barbara, for the report. I'm sorry, Margaret.
Quick question. Nick Tribble, BBC journalist, health journalist, has made he surmises that the 4-hour target has an impact on emergency admissions, because as people get towards the end of that 4-hour period, there's a sort of panic and on the side of the practitioners who think, oh my goodness, we need to do something with these guys in order that they're not still hanging around. So, so the last 10 minutes you're more likely to be admitted in order to get you off the 4-hour target. Is that just journalistic cynicism?
We can't say that never happens, but if you look at what really happens, those people who are admitted in the last 15-20 minutes before the 4 hours tend to be the longest staying patients. So they are not patients who are literally, you know, brought in to avoid missing the target and then discharged straight after. They tend to be and the NAO report that was recently published set this out in really good.
It is important to remember that one of the reasons that the standard we use is 95%, not 100%, is that there are patients for whom it is better to stay in the A&E department longer, and therefore we've got the facility for that. But you know, the evidence is that if it's more than 5 out of 100 of those patients who are being admitted to our sources, then actually that's us not being efficient rather than in the patient's best interest.
Thank you.